Well, I think the mallet actually is something that in every course I teach, I tell people that it is a absolute essential for their practice if they want to do implantology or any kind of oral surgery. Why? Because the mallets, if you look at traditionally, have been used in medicine and in dentistry for probably over 200 years or more. And when we look at the history of orthopedics, the mallets have been one of the main things to be used in orthopedic surgery. However, the problem is that the mallet was an uncontrolled device. That means you didn't know how hard to hit it. You didn't know, you couldn't measure it. You didn't know how far you are advancing with the mallet. Even if you were using osteotomes, I was taught back in the 90s, we were taught osteotome technology, and osteotomes were merely your tactile sensation. There was no control over anything. So with the mallet, the biggest advantage is, number one, it is a controlled movement, very, very controlled movement. You can control even the direction where you're going. You can have a better force. So you can, like on the mallet, you've got those 4 settings that are depending on how the magnets collide with each other, and that's the force that is being generated. So we know already all the algorithm, and we can finally start to be more comfortable using the mallet in situations where we were using osteotomes with much more confidence, merely just because it is a very, very controlled device. So anything that you can control is always better. So that's what my opinion about mallet is. To answer the question.
So, and do you think there is a specific anatomy or type of cases where the use of magnetic mallet is beneficial? So can we frame this within a certain type of cases?
I don't think so, because pretty much mallet is something that I use for almost any procedures that I do within the realm of implantology, right? I don't use mallet as often for extractions. I would only use the mallet if I broke a tooth or a root and I'm not able to get it through a luxator. Then I will go slowly with the mallet and I'll try to remove it. But otherwise, for any other procedures, and I will show you in a minute, when all the different things I'm doing, I couldn't put all the things together, but I'll show you the majority of the things that I do, and pretty much anything and everything that I can use the mallet for, I'm using it. For things that, people thought are crazy, but, for tacking membranes, I have given incisions with the mallet also. Incisions and reflecting flaps with the mallet.
Okay.
People don't believe it, but I show them how to reflect a flap with the mallet.
Okay.
Because sometimes the tissue is so fibrous, you can't use a periosteal elevator. It takes a lot of effort, number one. Number two is that because it is an uncontrolled movement, while the clinician is trying to push the flap away or reflect the flap, it slips and goes into deep into the vestibule, can hurt the anatomical structures. But with a mallet, it is so easy. So pretty much anything and everything that I do in implantology can be done with the mallet, pretty much anything.
Well, it's about force, so a lot of efficiency controlled, which is
exactly
the base to do a lot of things.
Absolutely.
Okay, so I know you have a very interesting presentation to show us. Yeah. Let's start.
Okay, so for me, you compare the drill with the mallet, right? This is the first thing I talk about, is what does the drill do? Okay, the first thing that the drill does is that it cuts away the vital bone. Okay, it removes the bone, increases heat. Whenever there is a friction And of course, there will be some frictional heat, as we know from papers that have been published over the years, that no matter how much coolant you use, there is still going to be some amount of heat during the preparation of an osteotomy with the drill, and the main part is that you are taking away that vital bone from your site. You're taking it away from there. That is what you need in there, and we are taking it out unnecessarily, So the mallet, what it does, it compresses the bone, it maintains the vitality of the cell to a large extent. I'm not saying 100%, there is still some heat generated with the mallet as well, but it is significantly lower compared to a drill. And one of the best examples I tell my students is when they don't believe me, I said, okay, let's take a drill and run that drill at 500 RPMs with saline and hold it in your hand and run it for 10 seconds. And let me see what happens, right? And then I tell them to use the same thing with the mallet. I said, hold it, and now I'll run the mallet 100 times. And you tell me how much heat was generated. So really, you have to be very, very practical, and some people just disregard the importance of the mallet. But again, to those people, I say, historically speaking, we've been using this mallet for over 200 years. Nobody complained at that time. What is the reason for you to complain now? It works. The bottom line is mallet and osteotomes have been working for many, many years in practice of dentistry and in medicine, especially orthopedics. So the vitality of the cell we know will be maintained. And most importantly, what I feel is that it displaces the bone. Instead of consuming the bone, it merely displaces the bone. And you will see some examples of what I'm doing currently and working on with the mallet, how I'm displacing the bone and creating things and making it more atraumatic. So here's a case.
Can I just ask you a question on this regard? Yeah. Because displaces the bone, someone says that with the mallet, you actually bring or move the bone where you need it. For example, when you have to push a septum, or when you have to, I don't know, make a sinus narrower. So displacing is preparing the anatomy the way you need it for implantology. Is that an appropriate way to say it?
Absolutely. I agree with that statement. Yes. So this is a very simple example of what the mallet does. As you can see, there is a facial dehiscence in this bicuspid area. And to do, you have about 5 millimeters of crestal bone. You will do the osteotomy. With the osteotomy, it consumes most of the bone in this area. So how do you maintain it? They have been using expanders in the past, and they talk about using expanders. But really what you want to do is within the given 3.5 millimeters of space that we have over here, can we do something to maintain the facial bone in this area and internally just cause compression and condense the bone and also increase the size of the osteotomy? So over here, you can see that we have increased it by almost 1.5 millimeters with our mallet. And not only have we done that, we have shaped the tissue differently. We have created the normal anatomy because there was the dehiscence on the facial over here that you see. After using the mallet, what you see is we got the buccal plate, which is almost straight in line. Okay. I mean, it should be convex, but it's still better than concave. At least we got to a straight line without the use of any graft or any advanced procedures, right? This is another example. Once, one of my colleagues and some of the colleagues, initially, I'm talking this about 4 years ago when I started using mallet with you, and they start questioning the authenticity of the mallet and what it does and the heat generation factor and all these other things. So this is one case that I did. It was very interesting. The patient walked in. We had to do 2 implants. So on the right side over here that you see on number 7, we used the magnetic mallet to do the osteotomy. And on the left side, we use the drilling protocol. And I want to show you the difference, what happened. This is almost 3 months after the surgery. Stage 2 was done. And during the stage 2, what we find is that you see that area of inflammation on this area where we had drilling protocol. Why? Because the facial bone had almost disappeared. Now it's the same bone type. It's almost like a split mouth design study, right? You're trying to do it, right? It's just one case, but it's a very good case to make people understand the difference between drilling and the osteotomes. So you see over here that the inflammation is present because we lost the buccal bone, right? This is again, see, although the tissue seems to be okay, but in here, when you look at over here, there is a buccal bone loss, right? And this is the mallet size. You see the mallet in this, both restorations were done. And look at the healthy tissue along with the mallet size and the unhealthy tissue over here. So this is just one example to show people that when we are expanding an osteotomy, mallet is more effective than any kind of a drill. You can change the drill shape, size, whatever you can. You cannot change the amount of heat that it is being produced by the drill. And there is absolutely no comparison to that heat with what we get from the mallet, right? With the drilling protocol, what happens? You are drilling slowly with a lot of water in it. And what happens? You get this entire area over here. This is your osteotomy, right? That initial osteotomy that you get. Now, once you start tapping the implant into this, what happens is that you lose the bone. The bone is gone, right? You lose the bone completely. Here is an example. This was done with the mallet. The extraction is being done here. The root tips broke. We took it out. Now here is the island that we have to work with. This is 3.3 millimeters, and this is done with a mallet. Okay, with a 200F, it was done, and I got it up to a 3.8 millimeter width. Now I can get my implant a 3.75. We got our implant in, and what you see is that there is still vital bone all around the implant itself. So that means that provided your implant design doesn't, totally destroy your osteotomy, it is very feasible to maintain that bone with the mallet instead of a drill. Okay. We add some bone graft or usual protocol, you cover it up. And this is another interesting case. And I bring this up because this patient came in and we were planning a lot of different implants on most of the sides, somewhat immediate. Pretty much every implant, including the mandible, I have used nothing but the mallet. So just to give you a perspective, this is the left and the right side. And here's the occlusal view. We are also going to do some crowns on the top on his upper molars. This is the gentleman from here. So this is an extraction, and all I'm doing is merely a little dot, and then I start with my osteotome, with my mallet osteotome, and I start preparing my osteotomy, right? And you can direct it. You can direct it the way you like, right? And then we place our implants, and implant goes in fairly easily after the osteotomy has been done, right? And I will show you some of the pictures of what happens after we do this, right? Now we have a case where, and then we place our implant over here. Okay. So you can see that not am I only going to get a good bone density here, but what I'm also getting is a higher torque value. So this torque value, you heard that noise, it tops out. It is at 60 newtons. So a bone that would have given me about 40, 45 tops is now giving me about 60 newtons. And not only that, I have to hand torque it to infinity because I have condensed the bone so far. And this is
I have one question, Dr. Panjali, on this. I have one question, if you allow, because it's a question we are, in Osseotouch, we are asked a lot. Have you ever had any issue with overcompression when you use the magnetic mallet? With reabsorption because of overcompression?
Yes, that's a very valid question. So the science behind it is that bone is like a sponge, okay? When you expand it, it pushes the cells out, okay? But the cells are still intact. All you're doing is compressing the cancellous spaces that are there, okay? Once you have gone after a certain beyond certain point, and the beauty of this is the mallet will tell you, you have to hear, you have to have a good hearing and good tactile sensation. When the bone cells are fully compressed, it will make a very hard sound, very different sounds, almost like you're beating up on a stone, okay? Once you get there, you stop. If you go beyond that point, now you are causing problems with the bone. Now you're killing the cells. But until that point, all you're doing is merely compressing those cells. That's about it. So you should know the limits. You should know how the bone behaves. And if you are still not sure, then the best way is you put the mallet, do 2 taps, 1, 2, stop there for about 30 seconds, wait, count to 30 seconds, then go again, 1, 2. So the 30-second is enough for the bone to revitalize itself and rebound itself back.
That's
beautiful. Revitalize the bone.
That's beautiful, because we're going from drilling bone away to shaping, to leverage on the elasticity of living bone. And this is something that you can actually see with your own eyes when you're working the patients. It's nice, seeing the bone shrinking back. It is about minimal invasivity.
Yeah. So again, so in the same case that we did the immediate placement, now you can see that there is bone all around it. You see that? I mean, there is no bone breakage like I showed you that happens with a typical drilling protocol, that you break either the mesial or the distal wall or the facial wall. It just disappears when you tap it. Why? Because there's no elasticity left. When there's no bone cells left, there is no elasticity. That elasticity is gone. But the osteotome maintains the elasticity of the bone. And this is what we did. We did the regular placement, we did the immediate placement. And now this is another important thing. This is a case that people should, a lot of these companies, they are making these sophisticated sinus lift kits and teaching this elaborate protocols on how to lift the sinus from a medial aspect. So we are not doing a lateral sinus elevation in this case. We just want a little bit, our direction of implant placement is right here. So how do you lift the sinus just in this spot? What drill can be used? And to my experience, we have used some drills that have come concave, convexes, drills with no cutting edges, and we've tried those things, but failures happen almost every other case. But this is what I did with this. So I'm doing a mallet, and the entire preparation of the osteotomy is being done with the mallet, right? And then I take my implant, I place my implant here, right? And once the implant has been tapped, now I'll show you what happens radiographically. Now you can't see it while you're doing it, but post-operatively, when you look at it, this was our sinus. This was our direction that we were going in. This is our implant. Now, see this. And look at what has happened, what the mallet did. Okay? It displaced the bone. It's displaced the bone in the direction where I wanted the bone to go. So again, I am in control. I'm in control. I know where I want the bone pushed. But the key in order to achieve this is that you cannot drill. You just have to osteotome the entire osteotomy. That is a key. So you're not consuming the bone, you're basically pushing and displacing the bone in the direction that you want it to go.
Well, and there is
there
is also another aspect, I believe, in a case like this. When you use the mallet is very forgiving, because if you're not happy with the inclination, you can still go back and modifying it.
Absolutely, you
Something
can,
that
because it's
obviously
merely
is not doing
displacing
the
it.
trick.
Yes,
Yeah.
exactly. Yeah, because it's merely a displacement of bone. So this is what I call, in my lectures, I call it a vital bone displacement. That means this whole bone is vital. Now you will hear some of the other companies saying, oh, you drill, it throws the autogenous bone up there in the sinus, it lifts the sinus up. It is devitalized bone. Why don't we understand that? Okay, it is devitalized bone. It is not vital bone. This is vital bone. This is vitalized bone. So you can see the placement of the two implants. The same thing I did on the lower. We mark our things, we place our implants. This is the final result, which we get with his crowns and everything. And let me show you almost a year after, you can look wherever we use the mallet, how beautiful the tissue is. Hardly any shrinkage. Bone remains vital. There is no bone grafting needed. With bone grafting, there is always some shrinkage that is associated. But with the mallet, if you know how to handle the mallet very well, you are not going to get shrinkage. The shrinkage will be almost minimal or almost non-existent, right? So when we talk about cases like this is a case from one of my classes. I'm teaching one of the students, and you can see we had about 5 millimeters of bone right across the board, right? And the protocol for this is that we do the drilling protocol. Then we do our mallet. We use our osteotomes to finish our, our osteotomy. And once the osteotomy is done, then we are going to split. So we use initially the blade. Now you can choose not to do it, but for my students, it's just easier to use the blade first because they're not used to the mallet, right? So I let them make the initial incision with the blade, and then we start to use our the splitters, right? And you go in at a power of 1. You always start at a power of 1, the 1 power, and then you slowly incrementally increase it if it is needed. But usually the 1 power itself is enough to split the bone. And then after that you're done, you start placing the implants in, yeah? And you have to be obviously very careful because you cannot put a lot of pressure on the buccal bone when you split the ridge, right? So your direction has to be more towards the palatal bone and not towards the buccal bone. Once you get your implants in, now always with the split, you will realize that, you have to add some allogenic bone around it just to give that volume on the buccal bone. You do that, and now you can see that within no time, we have gone from 5 millimeters to about 11 millimeters of bone width, okay? So how easy it is to do it with the mallet. There's nothing. This is another example I give people. A lot of people do these things. These are an example of, we did the osteotomy, and the bone felt fairly, okay. We did everything. We placed the implant and we started to torque it in. And because the bone wasn't dense, the implant was displaced totally into the sinus. And over here we have the sinus. And had we densified the bone initially, this would have not happened, right, in the first place. And you start to see, and now you're wondering, what am I going to do? So the only way is to do a lateral window and pull that implant out from there, right? And then place another one, as you see in the window. So bone condensation is an important aspect in implantology, especially when you're getting closer to the posterior maxilla, where the bone quality is very, very poor, right? People plan out these cases very diligently. So this is one of the cases that I was working with, one of my 3D guys, and we were placing 3 implants. And the key again over here is that no matter how accurate this system can be, we do our due diligence, making sure that we find the bone anatomy. But the anatomy of the sinus floor is never flat. It is never straight. So how do you manage this case? Without doing a lateral sinus, it is very hard to predict a case like this. And they said, you stop here with your osteotomy, with your surgical guides, and from there you start using your osteotomes. I said, are you crazy? I don't need your surgical guide, just get rid of it. I'll do it myself, and it is so much of cumbersome. There's so much and they make your life more complicated. You're supposed to make your life easy. This is complication. Measuring every little millimeter. Are you crazy? No, I'm not. I don't have so much time. Okay. So although this is a great diagnostic tool to have with you, sometimes it is just easier to freehand these cases. Okay. So you can see over here, we freehanded with the mallet. Everything is done. It was done in a normal manner. And I'll show you what we are doing right now. The treatment challenges with the pneumatized sinuses, crestus versus lateral. What are we going to use? D4 bone in the surgical site, we have to modify the bone by condensing the bone. Poor bone stability is when you have poor bone, not only do you need condensation, but you also need to have an implant system that has the thread design that is more appropriate to these cases. And sometimes we use some bioactive modifiers around the implants in the bone and some other things to get a good result. So here's a case which I show in a lot of my lectures. This is how the process of my technique started, where I was in my new office. We were doing these bunch of sinus lift cases. One of the companies was coming here to record my case. They were doing a video recording of my case. And my staff forgot almost everything that I used for sinus lifts. Luckily, in the institute, I had that magnetic mallet kept. That was the only thing I had at the time. But I want to show you what happens. Okay, we did the lift, we did the placement, and I'll show you the protocol, how it is done. But what you notice is that after the mallet was used, you see the green and blue bone around it. That is a representation of a D1, D2 type of bone. If we look at the initial situation, it wasn't that D4. So you look at the initial bone, it was mostly, you can see the red and orange colors, and the implant was being digitally placed or for a planning purposes. And as soon as we place the implant, after doing the mallet, you can see everything has turned green and blue. So what it tells you is that the mallet has condensed the bone that was present, which was a D3 type of bone, to a D1 type of bone and D2 type of bones maybe. So this is one of the key elements for sinus elevations, is to compress the bone, condense the bone. Look at the final results, what you get with this, and how beautifully the Schneiderian membrane has been maintained. The healing is perfect, every single time we do this. So cases like this, now you see this after almost 6 months before I referred back, and now you can see the blue coming through. All right. After the green, now it is turned into blue. So this is a D1 type of bone that we are working with. So even during the healing phases, you can see how good the result is. And what you also notice is that other than the graft shrinking, there was no shrinkage all around the bone that was compressed. No shrinkage at all, hardly anything. We talk about the Schneiderian membrane, and people ask me, how do you know this? And we know that the Schneiderian membrane can be stretched up to 132% and can be elongated in 2 dimensions. And that is why we are able to do this sinus lift very easily. And the biggest factor that causes perforations in maxillary sinus is really boils down to surgical technique. And if we can get away from those older techniques to the mallet, it is more predictable, because mallet has no cutting edges. It is merely displacing the bone. So the failure rate would be highly reduced. People also talk about the additional risk factors. If you go into the history of sinus or you look at the literature, you see previous sinus surgeries, absence of bone between sinus mucosa and oral mucosa, irregularities of bone, sinus floor, such as sharp edges, antral septa. And I showed you these cases, which I showed you, which was being digitally planned. It was not a flat floor, it was all around. It was not a flat floor. So you don't know. And when you get into a situation like this, there is a higher chance of you rupturing the Schneiderian membrane. However, in these cases where you're using a mallet because you're displacing the bone, the chances of Schneiderian membrane breakage is very easily. And people say, oh, won't the Schneiderian membrane break? No, I just showed you. The literature says you can stretch the membrane by 132%. Okay, almost 100% in even in a two-dimensional area. Okay, if not talking about three-dimension. So all these factors are important. And this is how I actually came up with my technique. And since this time, since this case, I started using this technique. I teach this technique to all my, my clinicians who come to the live surgery course. And I tell them the previous protocol was mallet and saline, the old Summers technique. It is the same Summers technique, but just a little bit modification here and there. So instead of using a mallet, I'm now using the magnetic mallet, okay, which is more controlled force. I have better control. So as we know that when you activate the mallet, it only advances about 1 millimeter at one given time, right? So you know exactly where you're going with the sinus elevation. You can pre-measure everything. But taking a hammer and banging it off like this, it seems so like somebody's coming and banging you out, right? So the patient feels that, very uncomfortable when you take a mallet and go to the patient's mouth, right? It looks so ridiculous. You look like you're still in the 18th century, So the protocol is very simple. You start with a little hole into the cortical plate. And from that point on, all you're doing is the mallet. You're just using the mallet all the time, okay? And you take the, so again, here's the mallet again. And all you have to do is just tap, 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 go in, and you can raise the sinus floor very easily. And then we push the saline. We use the saline, simple syringe. We push it and we pull back. And we know once the bloodstream comes through, that means there's no perforation in the sinus. All right. When the bloodstream comes in, we know there's no perforation. Now we can start packing our bone into that area, right? Whether you want to use PRF, I like to use PRF first against the Schneiderian membrane, and then I will start to pack some bone into that osteotomy. And using this technique, obviously there is a certain level of skill that the clinician has to develop with the mallet before they can do this, right? So once they have developed that skill, then it becomes a lot easier. And here is our implant placement. And again, you will see that we will torque out at about 60 newtons. We'll just torque it out.
Going straight.
That's it. And it's going. And so there's high density bone. And look at these results when we get with this technique. All right. Even up to where you have just 1 millimeter of cortical plate left, I can use the same technique using a mallet. I can open the osteotomy, displace the bone, and we can get a similar result over here. Again, PRF. And after the PRF is placed, we start packing the bone in.
Carolyn?
And I have done this. And look at this, 3 months later, after a case that was done, where we had the bone here, just with the mallet, I was able to do this. And people, when they see this, they say, hey, what's going on here? It can be done. You just have to know how to use the mallet. It is really boils down to how you can use the mallet. And the trick is not to think just outside the box, but to realize that there is no box to start with. We know about the clinic here. I train these people. We have a staff. You've been here before. All these guys come and they learn. We do full arch cases as well.
Let me ask you a little bit more specific about this, because let's say I'm a doctor based in the US. I bought the magnetic mallet and I'm a beginner in implantology, or I have a lot of experience, but I want to learn the way I can use the magnetic mallet. I want to learn your protocol for sinus lift. So what are the options offered by the New York Implant Institute?
So we offer, see, magnetic mallet is taught at all levels in my courses. Starting from a little advanced courses, we have 6 levels of education. And I start teaching the mallet right around the 2nd level. So level 2, I start teaching them. I introduce them to magnetic mallets, primarily starting with extractions, simple extractions, wisdom molar extractions, third molar extractions. And then I slowly start to take them, because once you do some extractions, you will have a good tactile sensation of how the bone behaves. All right. And then when you come to the level 3 in Colombia, that is where during the live surgery, almost except for the first day, I start teaching them about the mallet in the 2nd day. So from that point on, they are doing osteotomies, ridge splits, sinus lifts, everything with the mallet.
Everything, yeah.
And pretty much everything is being done through the mallet. And, it becomes so essential, because once they realize how difficult it could be without the mallet, once they use the mallet, now they don't want to go back to anything, right? So as you know, we keep asking you, okay, we need more stuff for the course. But, the idea is that mallet is essential. People ask me, how often do you use it? I said, I use it for everything. This is my daily routine cases, right? I do extractions and full mouth cases. That is 90% of my work. And even all on 4 cases, you will see I don't use drills. So over here, we are merely just using mallet alone, just the mallet alone, to do the entire osteotomy, all on 4, non-guided surgery. And look at this over here. We go from one area to the other. Immediate placement sockets. The implant goes in, and you will see the torque is so high, because for one of the criteria for immediate loading, all on 4 or all on 6s for immediate loading, is that you get a high torque values. How do you get a high torque values? You can only get a high torque values when you have a condenser bone, when you have a good quality of bone. So now you can see that in this case, we are literally gone to almost infinity to get the higher torque. This is another number 7 osteotomy being done, again with the mallet itself. Right? And you can see how well we got that osteotomy done. Even in cases where there is, a delayed placement protocol, all I do is I go through the cortical plate with the burr, with the pilot burr, just a little dot over there. And from that point on, all we are doing is the mallet right here. Okay. And this is a very, very soft bone. This patient had about D4, D3 type of bone, pretty much everywhere in the posterior region. Okay. And we were using the mallets throughout the osteotomy, preparation of the osteotomy. And you can see it, and you can direct it, like I told you, you can direct it wherever you want it. And like you correctly said, that you can change the direction mid-procedure, because all you're doing is displacing the bone.
What does the patient feel? That's another very common question.
Patient just feels the noise. The patient just feels the noise.
Yeah.
Again, with the mallet, the resonance, with the hand mallet, the resonance is so much that the patient feels headaches and all those dyslexic symptoms, but with this, it doesn't happen. So patient is very comfortable. Other than the noise, the patient is very, very comfortable. So even in this case, when you see we are hand torquing, we have gone to infinity with this process. So again, now this is again a delayed protocol. Again, this is D4 type of bone, so I'm able to go, significantly into the bone without stopping. If it was a denser bone, then I'll stop and go. But in a D4 type of a situation, you don't have to really stop. You can just go. Okay, till the time you feel that, and you can hear that noise. I kept the volume up so you can hear that noise. Yeah. And you will, once you go from a softer noise to a harder tone noise, you have compressed it enough. That's where you stop.
Clear indication, the tactile exactly. and the sound.
Exactly. And this
You know
comes with
exactly where you are.
obviously your practice and experience. You
Yes.
need it, yeah, to do that.
Plus, I would like to underline that because there is no heat, so you use no water, and that means that the field of view is clear. So it's
Absolutely.
not only
Absolutely.
tactile and sound, it's also the view, which is
Yeah. View
optimized.
is absolutely very, very clear. And you can see now over here also, I talked out at about 60 Newtons. So this is what we're doing. So now the other important thing that I'm doing these days, that I'm starting to teach, just about a month ago, I started teaching this to people, is what I call as facially displaced furcation for immediate placements in upper molars. So what does that mean? Usually the upper molars, the facial bone is very, very thin. Okay, the literature says that the buccal bone will resorb by almost 30-40% during the healing phases. So what if I was able to displace some of the bone that I'm not really using during the immediate placement? So when we look at a socket like this, we have two. We have the furcation bone, the mid furcation bone here, and then we have the facial root mid facial bone in the anterior. That is usually triangular in shape. So the principle behind this process is to move this furcation bone. The wider part of the facial bone goes towards the facial, and it becomes a new facial bone. So all we are doing is displacing it on either direction, whether you go left or right based upon what the need is. So typically people would say you will start your osteotomy right here in the center. But for this particular technique, we have to go a little bit more anterior. And you cannot use anything but just the osteotomes, just the mallet for this purpose. So here's a case that we had a planned case through the lab. And what you see over here, what is happening is that they showed us that the implant, according to me, when I looked at it, the implant has been placed supracrestal. Yeah. This is a violation of the principle of immediate placement itself, first thing. So what happens, that their evaluation that the implant would be 2 millimeters or 1.5 millimeters short of the sinus was wrong. The real place where it should be is the blue line. This is the place where the implant prosthetic platform should go, which means we are 2 millimeters short here, right? In this case. So when it came in, I got the case. This is just one of the cases I'm doing. I took out, extracted the tooth, and then with my pilot drill, with the spear drill, I'm just creating a tiny little hole, just tiny little hole, so it can take me to the right direction. And then I use my mallet, and you will start to see how I'm displacing it. I'm pushing it more facially. I'm directing it more facially. And when I do this, what happens? Look at this. When the next I go to my 200, look at this, what happens. Okay. I'm going and I'm displacing it and pushing it more towards the facial. You see how it displaces and pushes the tissue off? And now we can place the implant, and you can see the implant. We have the facial bone right over here, right? Right over here. And the implant is going against that facial bone. And it stabilizes that bone fragment right there. So the chances of this resorbing are very, very less. Obviously, we'll fill up some xenograft or allograft around the socket to cover up those holes. But this is what we do. And it goes, you look at the torque that we have. This is just the interceptal bone. Remember that, okay? Interceptal bone, the torque is going up to 60, 70 Newtons. All right. And this is just amazing to see with the mallet. And again, you see, I have not done anything else, but I want to show you a radiograph. Look at the radiograph. Where are we? This is the sinus floor. We are already into the sinus, but more importantly, you see the dome shape that was created by displacement of bone into the sinus. So how helpful this is, you know, instead of taking the risk of rupturing the sinus membrane, doing a sinus lift, going through extra instrumentation, going through that extra effort, all you have to use is the mallet, and you can just displace the bone in any direction, facial, lingual, mesial, distal, apical, wherever you want to do it. It is so easy to displace. And so furcations can be managed. Use the furcation, the facial furcation, for something good that we are trying to do. So this is all I have for you. So I hope you.
it is amazing what we can do nowadays with the magnetic mallet. And you know what? I'm still thinking to the images you show, the one with the different colors, okay?
Yeah.
It proves how when you use a mallet, magnetic mallet or Osseotomes, you're actually improving the bone quality, okay?
Exactly. Well, and
Yeah.
that's why I took that, because this is the best way I can prove to people that it is working. And you can see instant result, instantly. You take a cone beam after you place the implant, and you see that the bone is condensing, the color changes.
You really surprised me with this presentation, because I knew that you've been working a long time with that, but wow, such beautiful cases and so direct. Okay, you can actually see everyday situations that are solved in a simple way, in a very predictable way as well.
Yeah,
So that's good.
And there are a lot of things that, you know, I told you I'm doing membrane tacks, I'm doing flap elevations, incisions, you know, pretty much anything that you have difficulty in instrumentation with, you can use the mallet. Extraction, of course, it is always very helpful to use it. And what I think one of the biggest problem, one of my clinicians, as a matter of fact, just called me yesterday. He just bought the mallet from you. And he says, Dr. Panjali, when I'm extracting the tooth, it is breaking the bone. And we talked about everything. And then I said, it's not making any sense. Walk me through the entire process. And the problem was, after talking for almost 15, 20 minutes, I figured out the problem was in the setting.
Okay.
He was using a setting of 3, where he should be starting with a setting of 1 and then gradually increasing it. So again, little things that can make a huge difference. So really the mallet is all about, you know, people, you know, sometimes when clinicians don't get the concept or don't understand how the mallet works, then mistakes can happen. But if they are trained well, and if they know how to feel the bone and when to stop, then I think mallet becomes a very, very essential part of everybody's practice.
So
and not
the
only
solution is in Bogota, right?
A solution is in Bogota. Yes, that is a solution. But, you know, hopefully we start some programs with you guys on just doing the mallet. I think training is the key factor.
Yes,
training is the most important thing.
The learning curve, like for everything, is there.
Yes.
But I've seen this multiple times, even at your courses in Colombia, when people are dealing with a case, an actual case, a live patient, the mallet, you're there over the shoulder, giving the right you know, instructions. It is a very fast learning curve, because it makes sense, right? It makes sense. Exactly. And there are a lot of risk factors that are not there. We're not drilling, we're not overheating, we're not making a mistake, and then how do you go back? So it's a very forgiving learning curve. That's the way.
Absolutely.
Okay, so thank you very much, Dr. Panjali, for having shared all this, and I'll see you very soon then. Okay.
Thank you, Claudio. Thank you. Have a great day.